Hello, everybody. I am Masoud Khadivi. The pleasure is mine to welcome to all participants around the world for the spine osteotomy webinar. Some moments are too special to post about, like this webinar. We are delighted that you have joined us. I will be glad to help you in any way I can. I give a special thanks to Professor Mehmet Ziridi for their hard work and excellent cooperation with us. Also to Dr. Onur for accepting my invitation for this webinar. Unlike other countries, today is the first working day in Iran. Thanks to all the colleagues in Iran close their personal jobs and participate in this webinar. Special thanks to the Honorable President of the University, Professor Qanaati, and Director of the Neurosurgery Department, Professor Shirani, and my mentor, Professor Abbas Amir Jamshidi and Professor Ketabji. Let's start webinar with the first speech. Question and answer session will be held at the end of each talk. The first speaker is Dr. Murtaza Faghi Joubari, Associate Professor of Neurosurgery Department, Shariati Hospital, Iran. And his talk is Introduction to Sagittal Balance. Please.
Hello, I'm Murtaza Faghi, neurosurgeon and faculty member of Tehran University, and I want to discuss about the spinal sagittal balance. I would like to thank Professor Khadivi for arrangement of the program and welcome our Turkish colleagues for joining us. It's a great honor for us to have you in this conference. Sagittal alignment of the spine is the keystone to understanding the biomechanics of many spinal disorders. Sagittal balance is defined as the equilibrium between gravity and muscular response of the trunk to maintain a stable upright posture, and is a condition that the actions of agonist and antagonist muscles of the spine are minimized with the goal of minimum energy expenditure and less fatigue. Historically, spine deformity management focused on coronal alignment, but nowadays many studies and reviews have shown that clinically sagittal alignment is more important than coronal alignment. During evolution, bipedalism was an important progress because it leaves the hands free and a human can easily use various tools, especially tools for defense and hunting, but it is achieved at the cost of more precarious and insecure overall balance, and it needs a delicate and complex muscular and nervous system collaboration. For example, apes move on their forelimbs and their spinal column has a single thoracolumbar kyphosis. In human, addition of cervical and lumbar lordosis to the spinal column leads to upright position and horizontal gaze. This figure shows different parts of CNS which are involved in maintaining upright posture, and it indicates the complexity and elaboration of sagittal balance. Definition of center of gravity and line of gravity is essential in analyzing forces on the spine and their biomechanics. Line of gravity is located slightly behind the femoral heads, and center of gravity is on this line in front of S2. Now I want to discuss role of different parts of the spine. The pelvis must be considered as a pelvic vertebra or first vertebra of the spine, as proposed by Professor Dubousset. Its basal location determines the position of lumbar spine and hence of the entire vertebral column. So for management of spine deformity, it is essential to know pelvic geometry. Pelvic incidence is defined as the angle between a line perpendicular to the sacral plate at its midpoint and the line connecting the same point to the center of bicoxofemoral axis. It is constant for each individual and independent of posture. So pelvic incidence appears to be the main axis of sagittal balance, and sagittal parameters must be adjusted according to pelvic incidence. This figure shows the difference between low and high pelvic incidence. A small pelvic incidence corresponds to a narrow pelvis, and a large angle indicates a broad bone. The sacral slope is measured between the tangent line to the superior end plate of S1 and horizontal plane. Vertical pelvis implies a low sacral slope, while a horizontal pelvis have a high slope. Pelvic tilt is defined as the angle created by a line running from the sacral end plate midpoint to the center of the bifemoral heads and the vertical axis. Change in pelvic tilt means turning of pelvic around femoral head, and actually it is an important compensatory mechanism. You know that pelvic incidence is the sum of pelvic tilt and sacral slope. As a consequence, individuals with high pelvic incidence can have a higher range of pelvic tilt and sacral slope and may have better adaptation to different postures. In this regard, some studies have shown that low back pain is more common in patients with low pelvic incidence. Pelvic tilt is variable in different populations, but most authors believe that normal pelvic tilt is less than 15 degrees and pelvic tilt more than 22 degrees is correlated with disability. As I said before, it's better to adjust other parameters of sagittal balance according to pelvic incidence. Optimal lumbar lordosis is equal to pelvic incidence plus and minus 9 degrees. Thoracic kyphosis is in harmony with lumbar lordosis, and it is smaller and approximately 3/4 of lumbar lordosis. Cervical spine is based on thorax, similar to lumbar spine and pelvis. Thoracic inlet angle is equivalent to pelvic incidence, and T1 slope is equivalent to sacral slope. Greater T1 slope is associated with greater cervical lordosis. This slide shows the similarity of T1 slope and sacral slope. In conclusion, spine functions as a global unit. Pelvic anatomy has crucial role in balance. Pelvic incidence is a constant parameter. Pelvic tilt, lumbar lordosis, and thoracic kyphosis can be adjusted according to pelvic incidence. Cervical parameters influence and are influenced by lower regions. Thank you.
Thank you very much. We are going to the next speaker. Dr. Ender Ofutu has a problem, and Professor Zilali is instead of him. Please, Professor Zilali.
Hi, everybody. Unfortunately, my connection is not very stable, but I wish I can have a good connection. Can I share my screen? Evet. Do you see my screen? Uh, Actually, I will start with spine deformities, general principles and descriptions. In general saying, there are two types of deformities. One is the kyphosis, the other one is scoliosis. And the fact is that adolescent idiopathic scoliosis, the surgery is mostly done for cosmetic reasons. Children at those ages tolerate a surgery very well and very low complication rates. Congenital scoliosis is harder to correct. The patients mostly have neurologic problems. However, adult degenerative scoliosis is very different from others because of osteoporosis, advanced age, comorbid diseases, and high complication rates. So if you look at the two general groups, idiopathic scoliosis and degenerative scoliosis, idiopathic starts before bone maturity, it's mostly flexible, and only deformity, no neurologic deficits, no pain. However, degenerative scoliosis starts after bone maturity in elderly. It is rigid. Pain and neurologic symptoms predominate and combined with lumbar spine stenosis. Is in geriatric population, the apex is at L2 and L3 mostly, and degenerative listhesis, lateral listhesis, loss of lordosis are very common. And problems of those are weaker bone, osteoporosis, more deformity by the time, and more comorbidities of those patients, and resulting complications, more common complications, and outcomes are less satisfactory. What should we learn for deformity correction? Actually, we must learn correction maneuvers used for adolescent idiopathic scoliosis. We must learn osteotomy techniques, but those osteotomy techniques can be used in some congenital deformities, but mostly in adult deformities. Interbody fusion techniques we must learn. And with those three main areas, if we improve our knowledge and experience, we can make a good deformity surgery. Now I can start with some classifications of scoliosis and then some kyphosis. As you know, if the cope angle is more than 10 degrees, we call it a scoliosis. And there is mostly an associated vertebral rotation. And terminology are congenital, neuromuscular, idiopathic adolescent for unknown reasons, and degenerative scoliosis, or somebody call it de novo scoliosis. In the incidence is mostly the adolescent idiopathic scoliosis, then syndromic scoliosis, congenital, quite less, juvenile idiopathic scoliosis, infantile idiopathic scoliosis, quite less numbers. But degenerative scoliosis is very common, especially with the increasing ages of the human being. In the infant idiopathic scoliosis, there are no associated abnormality. And according to the ages, you can call it infantile idiopathic, juvenile idiopathic, or adolescent idiopathic. Or somebody call it early onset or late onset. And the radiology must have AP radiograms and also some lateral radiograms. We must look at the COPE angles, and we must also look at the major curve, minor curve, and most of the time right thoracic major curve. This is the COPE angle measurement. This is the apical vertebra. We have an end vertebra mostly. We must define those vertebra. We must define the neutral vertebra. We must define stable vertebra and central sacral vertical line. And these are the measurements. There are mostly one major curve, one minor curve, but there may be only one major curve, or there may be double curves. And the flexion, lateral bending films, neutral, right bending, and under traction helps us a lot to see the degree of flexibility. And the radiology, structural curve and flexible curve terms we can use. Those structural curves are decided by bending films. Major curve is always structural. Another technique to define the rotation, apical vertebra rotation, Nash and Mu has described a grading system according to the pedicle symmetry. So this is grade 1, this is 2, 3, and 4 rotation. Yes, these are measurables. And the Lenke classification is one of the mostly used classification, which has 6 stages: main thoracic, double major, triple major, thoracolumbar, lumbar, and thoracolumbar, lumbar, main thoracic. This is one of the Lenke 1 adolescent idiopathic scoliosis, main thoracic, which was done corrected by a posterior surgery. This is Lenke 2 with double thoracic curve, Lenke 3 double major curve, and Lenke 4 triple major curve. Actually, we have to define also if there is a shoulder imbalance and pelvic imbalance. If we know them, we must make our designing according to those imbalances. And the maturation evaluation is necessary to evaluate that research sign or Y cartilage must be looked at, or Tanner Whitehouse scale must be looked at. This research sign is a historical one, which is very commonly used on the pelvic radiogram, and ossification of iliac bone apophysis. Total closing means maturation. Treatment options, if you look at the COPE angle, if it is less than 20 degrees, we can just follow it. If it's between 20 to 30 degrees, or in 5 degrees increase in follow-ups, bracing is enough. If it's more than 45 degrees and not controlled with brace, then surgery would be recommended. But it doesn't mean that more than 45 degrees will end with a pulmonary restriction. Mostly 100 degrees or more curves can cause some pulmonary restriction, and this is an absolute indication. Most of the time, even with 45-degree curves, the main reason of surgery is cosmesis. And also, curves and retrogrades are very important, and to decide which treatments should be chosen. If you look at the brace indications, 25 to 40 degree skeletal maturity incomplete, and you can make a brace indication. And if the reserve is very low, you can indicate a brace. However, more than 45-degree curves, reserve 3 or 4, so it means those are mature skeletons. And thoracic hypokyphosis and upper thoracic curve, those cases must not be braced. There are different options. I will not give much details. And the history of adolescent scoliosis is start with CAS, then Harrington rod distraction systems, then segmental systems, and nowadays it's mostly done using only pedicle screw systems. We less likely are using CAS or distraction systems. As I mentioned before, the aim of surgery is mostly a cosmesis. Severe curves may diminish respiratory function, balance problem in sitting and standing, and pain in lumbar curve may happen in adolescents, but it's not very common. Most of the time, they do not have any pain at all. And surgical principles: do not retard surgery after maturation. Sequence is the release, correct, and fix. And we must avoid sudden column lengthening and over distraction. There are different techniques: posture, anterior instrumentation, or combined techniques, but we are less and less doing anterior or combined surgeries. We mostly do posture instrumentations nowadays. And advantages are more familiar, better control of sagittal plane and pulmonary functions. Disadvantages: posterior muscles may get distracted, more motion segments are lost, lesser hump correction, and more infection rates. If you look at the correction methods in adolescent idiopathic scoliosis, distraction compression, derotation, rotation, and translation, and cantilever reductions are some techniques. Distraction compression is very easy to understand. Actually, you distract the concave side and compress the convex side. This is one example I have done years before. Derotation is turning the scoliotic curve 90 degrees, so then the scoliotic curve becomes a kyphotic curve if in 90 degrees. So then scoliosis is corrected. Translation is to pull the rod, to pull the vertebra to the rod from the middle of the curve. Cantilever reduction is to fix the thoracic segments with 2 rods and then pull the rods to the curved side, so then fix them in the distal side. Another technique is in-situ bending. You can bend the rods after you place everything in shape of the deformity. However, disadvantage is much stress on bone and implant, and you can cause also some neurologic deficits with this technique. And another one is the Schuffelberger technique, segmental correction. You make the distraction, compression, and translation in each segment, so then you correct it slowly. Less stress on bone and implant is the advantage. You can combine the correction techniques like cantilever reduction together with segmental correction, like you see here. Cantilever reduction and derotation maneuvers at the same time. And you can also add some release techniques with posterior facet resection, rib osteotomy, vertebral osteotomies, anterior releases, and others. In the past, we used to do some anterior instrumentations, but nowadays it's not very common. This is one example, which the surgeon has done a anterior correction via a transthoracic approach. Disadvantage is technical difficult. It may be kyphosing effect and more pseudoarthrosis, mostly abandoned. I will give you one example. This is a African patient, female, who came to me after adolescence. She was 23 years old. There was a 110-degree right thoracic scoliosis. She had also sickle cell anemia, and you can see here on the 10-degree Cope angle, apical end vertebra is T7, apex of the curve is T10, neutral vertebra is L3, stable is L4, and there was no shoulder imbalance, and caudal end vertebra was L2. My plan was to place pedicle screws in those blue spots and make an osteotomy here and make some rib releases, rib osteotomies on those sides, both concave side and also some convex side. Two osteotomies at T10 and T8. This is the design, and this is the end of surgery. This is after surgery. This is before surgery and after surgery. In infantile scoliosis and juvenile scoliosis, there are growth-friendly techniques like casting, rod blanching, and minimal segmental fusion. And these are compression-based tethering stapling, guided growth, Leukotrolle and Sheila, and distraction-based with growing rod or vector applications. Some orthopedic spine surgeons in Turkey are also using staples by making a thoracoscopic approach in the infantile scoliosis, so that they use a band and they tighten the band on the convex side, so then correct deformity from the convex side only. Another growth familiar technique is this magnetic rods. In the past, they used to do repeat surgeries every 1 or 2 years, but now they abandon those surgeries. They lengthen the rods with that magnetic system. This is the magnetic rod lengthener. In general, say, goals of surgery is normalize sagittal and coronal spinal columns, contours, prevent further progression, fuse the least number of segments, protect and or decompress spinal cord, improve cosmesis, obtain a solid biological fusion, and avoid perioperative complications. And I repeat my facts slide. Adolescent idiopathic scoliosis surgery is mainly done for cosmetic reasons. Congenital scoliosis is more difficult to correct. Patients do have neurologic problems, and there are great differences with adult degenerative scoliosis and promorbid disease and high complication rates. Probably I can finish my talk here because I have many other slides on the kyphosis reductions. I can give opportunity to talk to the other speakers. Thank you for listening to me.
Thank you, Mehmet. For your situation, if anyone has a question, please, you answer the questions.
Hi, Mehmet. This is Muhammad Majd. I'm a clinical professor at University of Indiana, United States. For idiopathic scoliosis, I agree with research 0 to 1 forecasting. Also, the other thing that you have to consider is triradiate cartilage should be open. If the triradiate cartilage is closed, the bracing is not going to help. This is one issue. The other issue, I have a question for you. When do you order MRI for patient with scoliosis, with idiopathic scoliosis?
Actually, some surgeons order MRI for all adolescent scoliosis, but it's not necessary. I believe if there are some suspect on congenital scoliosis, you must order it. Like if there is a hemivertebra or wedge vertebra or segmentalization failure, so then you must order, because you can skip a tethered cord syndrome or similar things. If there is any neurologic deficit or if there is any doubt about congenital scoliosis, you must order MR. What was your first question? Sorry.
My first question is opening of triradiate cartilage. That means if you want to brace a patient, I agree with you, the curvature should be between 25 to 40 degree or 45 degree. One of the criteria, research should be 0 to 1 or 2, maximum 2, and triradiate cartilage should be open.
Yes, you are right. I admit that in those interval, you can make a conservative approach, bracing or waiting, of just observing. Actually, bracing, we are telling it very easily, but the adolescents do not tolerate it well. Many adolescents don't want to use those braces.
The other point that I want to add to your talk is those cases with idiopathic scoliosis that normally the curvature is in the right thoracic. If you see a patient with left thoracic,
Right.
That's a red flag. You have to order MRI for them too.
You can order, yes. Although many of my friends are ordering in every scoliosis some MR, it's not very necessary. If the patient is a female at the age of 12 or 14 and the right thoracic curve, and there is no hemivertebra or wedge vertebra, and there is no skin stigmata, I wouldn't order a MR.
Hello, Professor Zilalim. Thank you very much for your presentation. I'm Dr. Rostami, Professor of Neurosurgery at Tehran University. I'm asking about the case that you presented, actually the African girl. Which kind of osteotomy did you use for this patient?
Hello, you hear us?
Unfortunately, I couldn't hear you.
Sorry, do you hear my voice?
Unfortunately, I couldn't hear you.
Now you can hear or not?
Now I can hear you.
Okay, thank you. Thanks again for your presentation. I'm Dr. Rostami from Tehran University. I'm asking about the African girl that you presented, the girl with the scoliosis that you did surgery with. Which kind of osteotomy did you use for this patient?
Yes, it is a wedge osteotomy from the convex side, a closing wedge osteotomy. In fact, in the kyphotic patients, we use posterior facet osteotomies or pedicle subtraction osteotomy. But here it is an asymmetric osteotomy to correct the scoliotic deformity. Because she was 23 years old, it was after maturation she came to me, and then we would not be able to correct it without an osteotomy.
Okay, thank you.
Thank you very much for nice presentation. The next speaker is Dr. Mohsen Rostami, Assistant Professor of Neurosurgery, Spine Center of Excellence, Yas Hospital.
Okay. Hello, everybody. I'm, as Prof. Khadivi said, I'm Dr. Rostami from Tehran University of Medical Science. I'm a neurosurgeon who works in spine surgery. In my lecture, I will try to briefly describe the method and actually the technique of osteotomy from the easiest one, grade 2 to, and then grade 3 and 4. I will try to be brief and finish that in 35 minutes. Actually, Prof. Faqih said about the importance of sagittal balance, so we can pass these slides. We know the markers, we know the landmarks, and also we know the index of sagittal balance. It was 2010 that actually Prof. Schwab in an article introduced the importance of lumbar lordosis, pelvic tilt, and SVA. The correlation between these parameters and the clinical outcome of the patients were shown in different papers in a series of papers over the past decade. There are 6 types of osteotomy, which described by Prof. Schwab, from grade 1, which is a partial facet joint resection, to grade 6, which is multiple vertebral column resection. In this lecture, I will try to describe the grade 2, 3, and 4. Grade 5 and 6 are something which are behind the scope of this lecture, and I believe that there are something other than simple osteotomies, so I somehow exclude them from my lecture. There are general considerations for a surgeon when he or she is trying to do a surgery, osteotomy surgery. The position of the patient is quite important. The duration of surgery is too long, so it's necessary that pat all pressure points to avoid pressure injury. The arm positions are important to be relaxed and in 1990 position and supported. We usually try to use an open frame table or any other table that allows the C-arm to go through and help us during the surgery. The abdomen must be free as all other spine surgeries to allow venous drainage. During every kind of osteotomy, the mean blood pressure of the patient during the surgery should be more than 80 millimeters of Hg. So it is necessary that the anesthesiologist be aware of the condition, and neuromonitoring is a necessary part of this kind of surgery. The anesthesiologist should be aware of the techniques of the wake-up test, and before starting the surgery, we should talk to the patient about the possibility of the waking up test. First, we start from grade 2 osteotomy, or Smith-Peterson, Ponte, or any other name that you call it. I said that the grade 2 is that kind of osteotomy that will remove the spinous process, the ligaments, and the ligamentum flavum, and we go from the midline to the both laterals, free the posterior elements and dissociate the superior articular process and the inferior articular process of every joint. This is what I call it grade 2 osteotomy. This is a method to shortening the posterior column. This only works when the anterior elements are not fused, so we can compress the posterior elements. The alteration of mechanical forces in this kind of osteotomy are on the discs, so it is necessary for every patient that we do grade 2 osteotomy, ask for MRI. The steps are as follow. At the first, a midline incision, as like any other kind of spine surgery, to expose the tissue. Then the spinous process and the base of lamina are removed to allow visualization of the lamina. Inferior facet of the, actually the superior articular process of the inferior facet is removed, and then the superior articular process, the inferior articular process of the superior facet is removed, and finally the flavum. This procedure is quite helpful, the most used one, the easiest one, and the simplest one for those beginners and those who want to start osteotomy surgery, spine osteotomy surgery. This is the picture that Professor Ponte showed in his article. Shows that you can see here that the superior articular process and inferior has been dissociated. The cord is shown and the flavum is removed. And here they are going to do the same here. After, actually in a standard grade 2 osteotomy, there will be no problem for the screws, and the screws should be placed and secured. It is necessary that the gap between every pedicle be open for at least 5 to 8 millimeters, because this is the gap. Then when we try to compress the patient and compress the for correction, this is the gap that should be filled with the bones. Actually, it is also very important to clear the flavum, because at the time of correction, when we try to compress the pedicle screws, it is possible that the flavum fall into the cord and make a compression on the cord. And the bony spikes should also be removed. This is a case of, actually, this technique was first introduced for for a patient with kyphosis with ankylosing spondylitis. But the most common indication of using SPO or grade 2 osteotomy is a patient with Scheuermann kyphosis. It seems that every millimeter of correction will give us a 1 degree correction is achieved per millimeter of the bone removal in every facet. It is important to use hemostatic agents during the surgery, and use bipolar cautery and gelatin sponge or anything that is needed to control the bleeding, because the osteotomies are surgeries which demand bleeding control. So the surgeon should be aware of the condition. In case that we had any problem with actually bleeding or with correction, we should reverse the correction, extend our facetectomy, and then compress again. As I said, this is the condition that mostly used for patients with Scheuermann kyphosis. This is a picture of a prop radiography of a patient with 14 years old, which I did surgery actually 1 month ago. We used 6-level grade 2 osteotomy and thoracic kyphosis of the patient from 83 degrees decreased to 50 degrees. We used a transverse process hook at the upper instrumented vertebra, and extended the lower instrumented vertebra up to L3 because the C7 sacral vertical line, because the sacral vertical line was crossing from L3 and not L2. This is also another patient with thoracic kyphosis who underwent surgery actually 1 week ago. This is also a case of Scheuermann kyphosis, but this one was a case of revision surgery, had undergone maybe 8-9 times of surgery. Pedicle screws were pulled out, and due to DJK, finally, all the instruments were removed, and we did the same surgery and multi-level grade 2 osteotomy for correction of the kyphosis. Grade 3 osteotomy is actually somehow the state of the art for every surgeon. Up to grade 2, I think it is possible for every surgeon who wants to start surgery. But in grade 3, you have to work with the bony elements in anterior column. So the scenario is somehow different. This kind of osteotomy is usually used for patients with a SVA more than 12 centimeters. And this kind of surgery can also be used in asymmetric manner to address coronal imbalance as well as sagittal imbalance. For doing a PSO, at least 2 levels upper and lower of the instrument of the body that we are going to do osteotomy are necessary to undergo instrumentations, at least 2 levels upper and 2 levels lower. But I myself prefer to do that with 3 levels. I've not still done any surgery with 2 levels because there are many papers in the literature, if you review the literature, that they've shown that in cases with 2 levels, upper and lower, the rate of failure is much more. So I prefer to do with 3 levels, upper and lower of the osteotomy. Most of the time we do PSO for patients which have undergone multiple times of surgery. So it is necessary that we remove the screws which are loose, which are inadequate, and upsize them to an appropriate screw to use from the strength of the screws during the correction. The laminectomy is quite important. If you are going to do a PSO for L3, it is necessary that do laminectomy for L3, partial L2, and partial L4 laminectomy. Otherwise, during the correction, you will encounter with neurological deficit. So it is quite important that you remove all the flavums, every particle of the bones, and also it is important to consider this when doing surgery for patients who undergo revision surgery, because you encounter you can see a bulk of fibrosis on the midline, and this fibrosis during the correction will push a pressure on the thecal sac and may lead to neurological deficit. So as much as possible, you should remove the fibrous tissue and free the thecal sac from the tissue. After the laminectomy, you should circumferentially isolate the pedicle that you are trying to do osteotomy. For instance, if you are going to do osteotomy on L4 pedicle, it should be circumferentially released from surrounded tissue. In medial side of the pedicle, you can see the thecal sac. In inferior part of the pedicle, the root of the L4 can be seen. In lateral side, the transverse process, and in upper part, the root of the L3 can be seen. So all the elements should be well defined. As it's shown in this picture, after complete laminectomy of this level, the root is released. The pedicle is shown here. the upper root should be, the distal part of the upper root should be seen. And then this procedure should be site for both sides of the patients. And then we go through the pedicle with a curette or rondure or anything else to remove the cancellous bone into the pedicle. To protect the lateral side of the pedicle from soft tissue, I usually use a sterile gauze for blunt dissection of the lateral surface of the body from the tissue. Put the gauze into and use the gauze to dissect the soft tissue from the bone and put a space between the pedicle and the soft tissue. Actually, I continue that up to the level that the lateral side of the body starts to curve. And at that point, we can stop. During dissection of the lateral part of every pedicle, for instance, in this case, pedicle L4, we should be careful and pay attention to the distal part of the L3 root, because the distal part of the L3 root will pass through the lateral part of the L4 pedicle in distal. So it is necessary that during the dissection, take care of the root. Neuromonitoring will also help us during this. I usually use the inferior part of the pedicle as a landmark. The bony edge of the inferior part of the pedicle is a landmark that shows me during the surgery that where is the nerve root. The medial part of the pedicle also, there could be a bony ridge that shows me that where the pedicle will finish in the medial side, and behind that there will be the spinal canal. But at the upper side there is a wider space because the upper root will pass from behind the upper pedicles, under the upper pedicle. So there is a space for working. I usually start with a rondure, and after flushing the pedicle up to the posterior surface of the body, use a curette to remove the cancellous bone from the body, and then use a temporary rod, because in this case it is quite dangerous, because if you don't use the temporary rod, it might happen that the patient translates and lead to a spinal cord injury. Use a temporary rod at the other side and start with the osteotomy and go from the lower part of the pedicle into the body. We can also adjust the bed and use the operating bed to correct and close the osteotomy. We can also ask our assistant to push the patients back toward the ground. All these maneuvers will lead to closure of the osteotomy. And then finally, if there is any change in neuromonitoring, I will reverse the procedure, as I said about the grade 2 osteotomy, and start again, try to release the dural, try to extend the laminectomy, and then start again. Actually, this has been happened for me just 2 times. This is the picture of a standard PSO. As you can see here, a wedge osteotomy has been done, and after compression, the upper and lower parts has been compressed on each other. Finally, I will tighten the temporarily small rod and then ask my assistant for bringing the long rod, and also use the long rod to for further correction. For instance, when you are doing a PSO at L3 and use a small rod between L2 and L4, you can also use Smith-Peterson osteotomy at the L4, L5 levels. And when placing the long rods over the short rod in the patient, doing some compression on the long rod can also increase the correction of the patients. It is also very important that never connect the long rod to the short rod. This is some kind of malpractice, because biomechanical studies have shown that in cases that the long rod and the short rod are connected to each other with a cross or anything else, this will put an additional stress on the long rod and will increase the chance of rod fracture. Usually, you know that there is difference between the size of the pedicles and the bodies between humans. So there is a normal variation. But in average, L3 PSO can correct the global sagittal balance in average of 9 centimeters. If you deserve more, if you look for more, you can do higher grade osteotomies, or you can do 2 levels osteotomy. In case that you are going to do 2 levels of osteotomy, I strongly recommend that there should be at least 1 or 2 bodies between the osteotomies. For instance, you cannot do 2-level osteotomies at 2 consequent vertebrae, in L3 or L4. If you are planning to do L4, the other one should be L2 at least, or L1. I know that Professor Anur Yaman will speak about the complications after osteotomies and current techniques, but a brief review of the literature shows that up to 20% of the patients will have transient neurological deficits. In my series, out of 90 patients who underwent PSO, 7 patients had neurological deficits. In 2 of them, it was permanent. But reading the literature, the rate of complications are from 2-3% up to 35% of neurological deficits. Unfortunately, the deficits are somehow related lower than the level that we do osteotomy, and are not detected by neuromonitoring. Up to 80% of the neurological deficits after a PSO will not be detected during the surgery, and this is an area that shows that the neuromonitoring is not that much reliable during PSO. Pseudoarthrosis is a well-known complications. This is a patient with history of 2-3 times of surgery. The last one was, I think, was 10 years ago. The patient underwent L3, L4, and L5 pedicular screw fixation and interbody fusion, and at 3, 4, and 4, 5. As you can see, the SVA of the patient was 13 centimeters. The lumbar lordosis was 19 degrees. And the PI was about, I'm not sure, but I think it was 62 degrees, PI. So there was a mismatch between PI and lumbar lordosis. The SVA was positive. And in this patient, we did a PSO at L3. As you can see here, a temporary rod was placed between L2 and L4, and L3 underwent PSO. Then the long rod was placed between from S2LR, double S2LR screws at each side up to the T10, which we use hook to reduce the risk of PJK. Lumbar lordosis has been reached to 63, and SVA is 1 centimeter. This is another patient. As you can see, the lumbar lordosis is 19 degrees. SVA is 7 centimeter. In this case, usually you might say that this case could also undergo SPO because the SVA is just 7 centimeters. And I said that PSO is appropriate for patients with more than 12 centimeters. But as you can see here, a fusion was achieved. And by use of SPO, due to fusion at the level of the disc, we could not reach to an appropriate lumbar lordosis. Again, by using the PSO at the level of L3, temporary rod and long rod, we reach to a lumbar lordosis of 60 degrees, and SVA is 1.5. This is the patient that we operated last month. As you can see, the patient had been undergone surgery 5 years ago, and fusion from L2 to L5. The screw at the L2 was also pulled out. And this is the appearance of the patient. Lumbar lordosis was 0 and SVA was 16 centimeters. For this patient, we did a osteotomy at the level of L4. Here you can see an intra-op image of the patient from the C-arm. This is the image that we took from our C-arm in the operating room, and these are the temporary rods that we used during the surgery. The lumbar lordosis was increased up to 41, and SVA was decreased to 3.5. As you can see here, the appearance of the patient, the head was placed over the pelvic area, and the kyphosis was addressed. Grade 4 osteotomy. This kind of osteotomy is somehow the extended type of the PSO, and we can use from this kind of osteotomy to achieve a correction rate of between 40 to 60 degrees. The cora, or the center of rotational axis in this kind of osteotomy, is at the level of the disc, which is between the body that we are going to do osteotomy and the lumbar and the vertebra above that. For instance, if we are going to do corner osteotomy at L3 level, the cora will be on the disc between L2 and L3. There are some modifications and some actually variations in these techniques have been developed by different authors. Actually, in Schwab classification, this technique was introduced as a closed wedge type, but due to different variations, somehow some authors do that with open type, because the wedge part will not go through this line. Actually, it will go through the posterior 2/3 of the body. So this could be classified as an open type. Some authors also extend that to the lower end plate of the upper vertebra. In this case, 10 more degrees achievement, 10 more degrees of corrections can be achieved. And this with this variation can be used as an alternative to PVCR or grade 5 osteotomy. Here in this slide, we can show the difference between corner osteotomy and PSO or grade 3 osteotomy. As you can see, in some patients with small pedicles, with small width of pedicles, a PSO, you can see the blue line, can achieve 26 degrees of correction. In this patient, a corner osteotomy will lead to 45 degrees of correction. But with a larger body and wider pedicle, a PSO can lead to 38 degrees of correction, and corner osteotomy lead to 56 degrees. So sometimes some of the colleagues ask me that why in this patient you do corner osteotomy and why PSO at other. It depends to the size of the pedicle. In some patients, you can achieve complete correction with a PSO, but in others, due to small size of the pedicles, it is necessary to extend the technique to a corner type. Actually, in corner, more bleeding, more complication, and more time to doing the surgery, and the techniques and also the load on the instruments will be much more. For doing this, all the considerations that I said about the PSO should be also included. For this one, it is necessary that the surgeon bend the rods before starting the surgery, because after going through the technique and starting the osteotomy, there will be no time for bending the rod. So I strongly suggest to prepare the rod for the patient, both the temporary and the long rod, before starting the procedure. It is necessary that due to high load on the temporary, very strong load of the forces on the temporary rod, it is necessary that you avoid damage to the rod or sharp contouring of the rod or repeated type of reversing the contouring. In case that you started to contouring the rod and found out that it is not appropriate for the patient, you should use another rod, because in case that you use that rod, it will be a rod break. The rod will be broken very soon. The rod can be bent nearly 90 degrees because of this type of the correction. And also it depends to the type that you are going to start. I start with the upper disc, find the disc, which is, for instance, if I'm going to start with the L4 corner osteotomy, try to find the L3 root, L4 root, and then go and find the disc between the L3 and L4. As you can see here, if we are going to do corner osteotomy at L4 level, L4 root should be well defined. L3 root also should be defined. The pedicle, all the elements at the posterior surface have been removed. The pedicle, which is shown here with P, is well defined, and the transverse process is here. Pedicular screw at L5, S1, and also pelvic screws, stular screws have been placed, and also you can see here the pedicle screw at L3. Then after defining the elements, actually we start again with the sterile gauze and place it between the lateral part of the pedicle at the L4 and the soft tissue lateral to that. Also ask my assistant to protect the upper nerve root, because during this dissection, as I said about the PSO, the upper nerve root will be in danger. Then I will go and start with dissectomy of the L3, L4 disc. The annulus and the nucleus pulposus of the disc should be completely removed. And then I put a marker. Actually, here you can see the disc. This is the pedicle of the L4, and this is the disc between the L3 and L4. I start with dissectomy from the lateral. During the dissectomy, you should ask the assistant to protect the L3 root, which is here, by a retractor. And using a knife, I start to remove the annulus of the L3, L4 disc, and then remove the disc totally. After removing the disc, I will put a marker into the disc and use a chisel or a osteotomy to go from the inferior part of the pedicle toward the marker that I have put on the disc. Look here, it is shown that the marker is placed on the disc, and here is the osteotomy. We go from the inferior part of the pedicle toward the disc that we have placed. As I said, in this technique, According to the first classification of Professor Schwab, it was a closed wedge type, and the osteotomy had to move from this part toward the anterior superior part of the body. But in other modifications of the technique, we go from the, by the osteotomy, we go from the inferior part of the body, inferior part of the pedicle toward the junction between the 2/3 of the posterior side of the upper end plate of the vertebra and the 1/3 anterior. During the osteotomy, it is also necessary to be careful during doing the osteotomy. The assistant should protect again the root and the neurological and the tickle sock should be retracted medially to protect it from possible injury during the osteotomy. After osteotomy, the bone, the cancellous bone of the body can be removed in an en-bloc manner, and the remnant of the disc of the upper disc between L3 and L4 should be removed by disc forceps and the lower end plate of the upper vertebra. In this case, the lower end plate of the L3 should be decorticated very well, because that's the surface which should have contact with the upper part of the cancellous bone of the L4. Again, we use the temporary rod, use the bed to erect the bed to close the osteotomy. And it is also very important to preserve the anterior annulus and the longitudinal ligament at the anterior part of the disc, because in case that it was removed, the patient will be at danger of the vascular insult during the correction, because the anterior part of the lower vertebra might insult to the vascular elements which are at the inferior part. After compressing, this surface will have contact with the lower end plate of the upper vertebra, which is shown in this image, and the correction will be achieved. As I said, here it is very important to save the anterior longitudinal ligament, because there might be a vascular insult, which is a very well-known complication of the coronary osteotomy. And I also had one case. It is strongly suggested that the surgeons use an interbody fusion at the level inferior below the vertebra which has undergone osteotomy. For instance, in this case, at L4, L5. If you are going to do coronary osteotomy at L4, it is suggested that do interbody fusion at L4, L5. This will improve the chance of fusion in the future. This is a case of coronary osteotomy. Actually, we did about 6 months ago. The patient had undergone fusion from S to T11 or T10. Positive sagittal balance. This was the appearance of the patient. We used the coronary osteotomy technique. As you can see here, the open wedge of there is a very good bone fusion between the posterior elements, between the superior cancellous bone of the L4, of the L3, and the inferior end plate of the L2. We also use the cancellous bone. We also use the temporary rod and the long rod. As you can see here, there are a couple of knots here and here. You can see there remained of the second surgery, and the knots were open, and we even didn't try to remove the knots because they were in the soft tissue. This is another case that the patient had L1, L2 disc. The previous surgeon had done L3 to T12 fusion for the patient, and the patient underwent DJK, distal junctional kyphosis. The screw at the L3 was removed. As you can see, the patient had some kind of osteoporosis. The T score was 3 negative. So we did a corner osteotomy at L4, which is here, and use a temporary rod. You can see that the lumbar lordose, which was +4, is now 42 degrees of lordosis, and SVA, which was 8 centimeters, has been decreased to 4.5. This is also another case that this patient was a nurse and undergone 8 times of surgery. Finally, from S2LR to T10, but with positive sagittal balance, the pelvic incidence was 42, and the SVA was 18 centimeter. We did a corner osteotomy at the level of the L3 and try to restore the sagittal balance. Still, the SVA is positive. It's 8 centimeter, but the quality of life of the patient has been much improved because the pelvic tilt has been decreased from 26 to 9.5, which is now in the normal range, and the lumbar lordosis has been increased from 1.9, actually around 2 degrees, has been increased to 42. And due to fusion at the level of sacroiliac, the pain of the patient has been decreased. I know, again, I know that that Prof. Onur Yaman will talk about the complications, but there is, in the literature, there has been an article in European Spine, I think this has been published, that you can see that in corner osteotomy, comparing to PSO, the duration of the surgery will be much, about 100 minutes more. The blood loss is almost the same. By the days that hospitalized is much more in the patients. Almost every patient who undergo corner osteotomy needs to do blood transfusion, both during the surgery and after the surgery. So the surgery is a very big, so decision to make a surgery and the decision to do this kind of osteotomy for the patient needs much more evaluation than other types of the osteotomies. Thank you very much.
Thank you very much, Mohsen, for nice presentation. So we will go to Onur Yaman. This is speaking about the complication management in sagittal balance surgery.
Can you see my screen?
Yes, yes, please.
Yes. First of all, I'd like to thank you, Dr. Mesut, and also all the organizing committee for this nicely kind invitation. So the topic is very difficult, but I try to make it simple, and I try to explain what I understanding about the sagittal balance concept and what I'm doing and what we have to do to avoid the complications of the sagittal balance surgery. First of all, we have lots of complications that my colleague Murtaza has explained very good in his presentation. So we have the compensatory mechanism for as a hip extension, knee flexion. So the only aim here is to keep the horizontal gaze. But in some cases, it's impossible to correct the spine and to have a good sagittal balance. And in some cases, the reason of the sagittal balance is different. So the patient was walking very good. He has a good sagittal balance, but 10 days ago, something has happened and the patient started to walk in that way. So again, in Murtaza's presentation, he talked about a little part of his presentation as coronal balance. The coronal balance, sagittal balance are all together. I have seen this fish in a pet shop. And if you see, if the both eyes are not in the same level, the fish cannot swim. And also this patient has not a good level eyes. So the patient start to do something different to compensate it, the horizontal gaze. I will talk about this case later. So all part of the spine is related with the other part. So I know most of you know this tale. This is a tale about an elephant, a tale from Mevlana Jalaluddin Rumi. So the tale is like that. They put an elephant in a dark room and they sent everyone into that dark room. They touch one part of the elephant's part, and sometimes some of them has described it like this is like a tree. The other part, other one touched the other part of the animal, and he said it's snake. So some of my colleagues sent me some X-rays, and they asked me, what do I have to do? So the sagittal balance has to be learned. This concept has to be used in the daily practice. If you use an X-ray that you cannot see the S1 at least, it means you're just touching the food of the elephant. But if you see at least the S1, then you can see a bigger part of the elephant. Because just seeing the S1, you may say that that patient is using the pelvic tilt. So this is the mechanism that a patient is using with the retroversion of the pelvis. If you see S1, the end plate of S1 parallel to the floor, it means the patient is using the pelvic tilt. Look, a very easy thing, if you have an AP of the pelvis, if you see this ring, it means the patient is a normal position, is in a normal position. But if you cannot see that foramen here, it means the patient is retroverted. The patient tries to make a compensatory mechanism here. This is the normal view of a patient, and this is a normal view of a patient who is using the compensatory mechanism. So if a patient has a sagittal imbalance, the patient tries to sit, like he tries to bring his whole spine to back. And if you look on the lateral view, this is the compensatory mechanism. So S1 gives us lots of things. So just looking at the S1 here, without making any measurement, we can say that this patient is using the pelvic tilt. The patient has a retroversion without no measurement. Because if you just give the numbers, the pelvic tilt, pelvic incidence, sacral slope, SVA, most of our colleagues get afraid of the sagittal balance concept, but it's very practical. We all have to learn it. So just looking to S1, we can say that the patient is using pelvic tilt. This is the patient who is using the pelvic retroversion. I know it because I cannot see the foramen here. So this is the normal patient's pelvis here. So if I can see the femoral heads of a patient, I have more details. I can see the elephant's more parts. So because I can measure the pelvic incidence. Pelvic incidence is a fingerprint of a patient. It doesn't change in time. And if I know the patient's pelvic incidence, I can measure lots of things. Like this way, in our classical education, we were asking our master, so how many lumbar lordosis will that patient need? They say that bend it to 40 degrees, bend it to 30 degrees. We don't know how many degrees we are bending the rod. So basically, we can say that the patient has 43 degrees pelvic incidence. So it has to be 40 degrees. These are the basic things. So the patient has 33 degrees. It may have 30 degree, 35 degree. In this patient will need 45 or 50 degrees lumbar lordosis. So you cannot bend the rod to all these patients. It cannot be the same. So we have one size jacket and we try to fit it all to one, but we need different sizes. We have to decide according to the patient. So if I know the pelvic incidence, I know now I have the proper lumbar lordosis now. So if I can see C1 or if I can see C2, I can see more details. I can say more things. Look, on this X-ray, I don't have any measurement, but this scoliosis graph, the lateral scoliosis graph, has a language. It tells lots of things to us. I can say that the patient is using the compensatory mechanisms because the patient has bent the knee. The patient is still using the compensatory mechanism with pelvic retroversion because I can see S1 is parallel to the floor. The lumbar lordosis has lost. The patient tries to keep the head over pelvis. The patient has a thoracal hypokyphosis here. Maybe we can say that the patient also using the cervical hyperlordosis to bring the head over the pelvis. And if you look at the measurements, it says the truth. The patient has lost the lumbar lordosis, has hypokyphosis. The patient has a great pelvic tilt here, and he cannot compensate it. So we have to learn the language of the spine. This was a case that we have operated because of Schauerman kyphosis. But if you look at the cervical area here after the surgery, we have overcorrected that patient. The head comes over back of the pelvis, and the patient tries to keep over the pelvis, but with cervical hyperkyphosis. So every part of the spine is related with each other. The first case that I have shown you at the beginning was walking very fine, but suddenly something has happened. Then the patient started to bend forward. And if you look just to the sagittal views, to the scoliosis graphs, you may decide wrongly. So the main problem here was only a disc. We have removed the disc, and after that, you see that all the sagittal balance has confirmed after the surgery. So we don't operate the X-rays. We have to listen the anamnesis of the patient. We have to see the symptoms of the patient, and we have to decide if it's a reason or if it's a result. So this fish has to be bring the eyes together parallel to the floor. If it's not like that in this case, and if you just look at the thoracic spine here, you may say that this patient has a thoracic scoliosis, we have to correct it, but this is a result. So if you just correct the cervical area, your scoliosis will correct it because this is a compensatory scoliosis. So we have to think what causes what, which one is the result. So sagittal and coronal balance are together. So the main thing that we have to do before the surgery, we need a good planning because there are lots of parameters here. So we have to know these concepts. So the pelvic incidence and the lumbar lordosis change to the degrees. If the patient's pelvic incidence is too high, you need less lumbar lordosis. If the patient has too low pelvic incidence, you have to add some degree on it. So you have to know it. You have to know the type of the apex of the lumbar lordosis. You have to know the distribution of lumbar lordosis. So, and age is another parameter. So we have to decide according to patient's age. So with lots of parameters, you cannot say that I'm bending this rod to 40 degrees. So 30 degrees will be enough. So you need a measurement for it before the surgery if you want to have less complication after your surgery. So I had lots of friends where good surgeons, and they say that you don't need any measurement. I can bend it. I give them 3 rods. I wanted them to bend it to 30 degree, 45 degree, and 60 degree. And you see how many different bending methods are there. So there is no relation with the apex of the lumbar lordosis, with the distribution of the lumbar lordosis. So it causes complication after your surgery. Maybe most of them, the pseudoarthrosis, the reason of pseudoarthrosis is just not bending the lumbar rod into proper position. So how do we make a plan? This was 72 years old, had previous surgeries and bent forward in time. You see, the patient cannot use the compensatory mechanisms here. So how do we decide and how to make, how do we operate that patient? So we need the scoliosis graph. So we have to make the necessary measurements. So my other colleague, Mohsin, has a good lecture about osteotomies. How do we decide the level of osteotomy, which type of osteotomy we have to use? So I use a software, it's SurgiMap. You can find it and download on internet. It's free. There are KEOPS, there are SpineCore, there are lots of softwares that you can use. So I have to know which type of osteotomy I have to apply before the surgery. I have to know I have to determine the level and the type of it. So I try it before the surgery. This is L4 PSO type 3. I want to see if it will be necessary or not. It's not enough because I couldn't bring the SPA to the normal range. Then I add a Ponte. It didn't work. I had a second one, but I have seen that it's not working. So I changed the type of osteotomy. I decided to make a L4 type 4 to L4 vertebra and a corner osteotomy. It was not enough. I added a Ponte, I added second. So it was fine. So if I apply a L4 type 4 osteotomy, and if I add 2 Ponte osteotomies on it, I may say that I will have a proper sagittal balance after the surgery. So that software allows you to give the shape of the rods here. So I decided to make a T10 to iliac screws here. So I know the shape of the rod here. So before the surgery, I have the shape of the rod. It helps me during the surgery. If I can put that rod very easily to the instrumented levels, it means I will get the proper position of the patient that I planned before the surgery. So these are known as pre-bending rods. I'm just giving to the company and I want this, bend this rod into this shape. So during the surgery, I get 2 separate C-arm views. So I have combining it during the surgery. So before the surgery, I was thinking 33 degrees lumbar lordosis will be fine for me. So I have measured it and combined it during the operation room. So I have seen I have the good lumbar lordosis. So this is after the surgery's patient's surgery. So before the surgery and after the surgery. And these are the clinical views of the patient. And this is the post-operative movement of the patient. So another ankylosing spondylitis case, these patients cannot use the compensatory mechanisms. I opened the eyes because while during the sitting, the patient cannot get the horizontal gaze while sitting. So, sorry, the patient was walking parallel to the floor. So we could not get we cannot measure the sagittal balance because the patient's head was out of the cassette here. So we have made the measurements while the patient was sitting. So we made the necessary measurements and we decided to make an L1 and also L3 pedicle subtraction osteotomy here. One of the complications, the difficulties of these surgeries are the positioning of that patient. So you have to be very careful during the position and turning the patient to the prone position. So this was the last position of that patient. I have climbed on 2 steps there. So the position is very uncomfortable. So all these procedures, we're using neuromonitoring. So after the surgery, the patient could sit proper and has a good horizontal gaze. Because the patient has hip arthrosis, the patient is going to get a hip surgery after this, this spine surgery. So you see the patient has a good horizontal gaze after the surgery. So as Mohsin has given us a very good lecture, in some cases we have to use the corner osteotomy, use an interbody cage to make more correction. The things that you have to obey during these surgeries, you have to be very fast. You have to prepare the temporary rows before the surgery, and you have to make decompression very fast, and you have to close the osteotomy site very fast, because if it's opened, you bleed too much. So this is a case that we have applied the L4 type 4 osteotomy. These were the measurements before the surgery, and we applied the L4 type 4 osteotomy, and we have corrected the spine. So during all these osteotomy maneuvers, we never make a compression, we never push it there, we just use the table. So the only thing that we're doing during the surgery, we deflexing the table. If you made the necessary decompressions, you check the nerve roots there, then the only thing that you want, you bring this patient's back the level of the osteotomy site at the bending part. So you have to try it before the surgery. So the only thing that you have to do is deflexing the table. So this is a case example that we have applied a pedicle subtraction osteotomy. If you cannot close it, so you have to check your nuts. They have not to be very fastened. You have to use the temporary rows all your procedure, because if you don't use that temporary rows, you may have a translation, as Mohsin said. The most difficult part is here. You may have a coronal translation, or you may have a sagittal translation here. So all these closing maneuvers, you have to see the buckling, but the most important one is you have to see the exiting nerve root here, okay? Because this nerve root may be under the compression at the upper part of the pedicle here. So you make a great decompression. This foramen is known as giant foramen. You bring two nerve root in a one foramen here. So all these maneuvers, while you're deflexing the table, you have to check the neuromonitoring. If you have any problem, you have to correct the correction maneuver. You have to bring it to previous position. And you have to see if there is a compression on the nerve root, and you have to see the buckling of the spinal cord. So this was a case that we have done 15 days ago. All these osteotomies, most of them, Ponte, Smith-Peterson, pedicle subtraction, corner osteotomies, are closing osteotomies. But sometimes you may need VCR or more than VCR. And while these maneuvers, if you don't put an anterior device before, just trying to close the spine, the posterior part, you may have a neurological deficit. So I have seen this technique from a video of Oechi. So we have tried it. So using 3 rods here with the dominoes here may help you to make the maneuvers very easily, and it prevents you the screws pullouts, because you're dividing all the forces in 3 rods there. And with the help of this temporary rod here, you're just distracting, but you have to be very correct of the over distraction of the spinal cord here. With this maneuver, you're correcting the kyphosis, and you have a place to put the vertebral body device inside. So we put a device inside, then you make the closing maneuver. So we use the temporary rods. We added some extra rods here to strengthen the system. So this was after the surgery. So we are using some extra rods to correct the sagittal and also the coronal balance. This was my first case that I have used kickstand rod technique. The kickstand rod techniques is depending on an extra screw on the iliac wing here. So the thing that we have done after the surgery, we had a good sagittal balance after the surgery, but we cannot correct the coronal balance here. Coronal balance is important as sagittal balance. So what we have done, we changed the direction of the screw here. Then we put an extra rod with a domino that connects to the main rod here. The only thing that you have to do is the distraction maneuver. So you put an extra screw on the iliac wing, you put an extra rod, you combine it with a domino with the main rod here. You use a strong rod holder. The only thing that you have to do is distracting this part. So this is the view of the surgery here. We just change the direction of the screw. Then you have to fix the iliac screw here. You have to loosen all the nuts here. It has to be loosened. You're fixing the iliac screw wing. You're using a strong holder and we're just distracting. So the spine is coming to the midline very easily. It's a very strong maneuver. So this was after the surgery. We have corrected the coronal plane, but the thing that you're doing on the coronal plane causes sagittal imbalance in the sagittal plane. If you're making a distraction maneuver on the coronal plane, the spine is coming to the midline, but on the sagittal plane, while you're applying distraction forces, the patient is coming to the front. This was before surgery, after the first surgery, after the second surgery, revision surgery. But if you look at the previous surgery and after the second surgery, we have a worse sagittal imbalance here. To prevent that, you have to use another rod to the other side. So think that the patient has a coronal imbalance. You have corrected that patient with a kickstand rod here, but you bring that patient to front. But if you add another extra rod to the other part, and if you just compress it, the patient will come back. So you will have a more strong system with double rods on both sides, and you can bring that patient to coronal and also the sagittal balance into the proper position. So now we are using double rods on the one side and double rods on the other side. This was another patient that had previous surgeries. We again use pre-bending rods here. So the thing that we're added here is we're using a T-shaped rod to see if the patient is well balanced on the coronal plane. We put this rod parallel to the femoral has, and we see if the patient has moved, has derived to one side or not, and we try to keep that patient on the midline here. The key point here is you have to bring that L4 parallel to the floor, so you may have less coronal imbalance after the surgery, before and after the surgery. So this case was operated before in another hospital. The patient has bad coronal imbalance after the surgery, and after 6 months, they had pullouts at the proximal part, and they have loosened the screws. The thing that we have done, we go to the upper part, we gone to the iliac wings here. This was before the surgery, this was after the surgery. So we're using lots of dominos during the surgeries. This case was done by me. So everything was very good after the early follow-up. Please look at the rods here. There were 2 rods here on one side, 2 rods on the other side. But after, I think 6 months later, you see this rod has come to the other side. So you have to be very careful using these tools during the surgery. It was very interesting case. So then we have the revision surgery. So the things that I can say at the last verse, we have to be very care about the symptoms. What are we treating? And are we treating just the pain? Are we correcting the spine? We have to decide if it's a result of, or if it's a reason. We have to all the time keep the sagittal and also the coronal balance, especially in the elderly patients. The preoperative planning is very important. You have to decide the upper instrumented vertebra, the lowest instrumented vertebra. There are lots of details there. So you have to decide the type of your osteotomy that you're going to use during the surgery. Preventing growth is a good option. T-shaped growth is a good option to get the coronal balance. Using dominoes will help you during the surgery. Another thing is the position of the patient. The neuromonitoring is a very important thing. All your maneuvers, you have to use it. And we have to know if you're operating the elderly patient, the osteoporosis is a difficult issue that you can not control. Even osteoporosis can stop you before the surgery. So I'd like to thank you again for this kind invitation. And I'd like to invite you to the 6th Congress of Middle East Spine Society that's going to be held in Istanbul between 23 and 25 September. Thank you so much.
Thank you very much, Onur, for very, very nice presentation. So I talk for a special guest, Dr. Majd, who is clinical professor in Indiana University, and his subject is sagittal balance. Please, Dr.
Good afternoon, everybody. I would like to thank Dr. Khadivi. The organization committee for this webinar asked me to be part of this symposium. My talk is basically about the type of lumbar lordosis and thoracic kyphosis that we have. As we know, a balance status is a physical state where the different active forces are neutralized. In the standing human body, we have to have a 7 plumb line, sacral plateau, and femoral head. We have to be able to see those to be able to make a decision. The question that's going to come out is the pelvic incidence is a key factor. Is angle reciprocity sufficient? Is angle reciprocity sufficient? And do we have to introduce curvature length reciprocity in the spinal segmentation? As Dr. Yaman stated, we don't have a one prescription for everybody because some people, as look at the left-hand side, the patient has a lumbar lordosis that included carpal vertebrae. That the second one, you see the lumbar lordosis go to up to L1. The third one, lumbar lordosis, go to the thoracic spine. And the fourth one, actually, we have more segment included in the lordosis. These are the patients that undergo surgery, and you see the patient underwent fusion with loss of lordosis and malalignment. What are the factors we are going to talk? One is the pelvic shape and position, pelvic incidence, pelvic tilt, and sacral slope. We know the sum of pelvic tilt and sacral slope is equal to pelvic incidence. We have a spinal shape that in everybody is different. We have lumbar lordosis, thoracic kyphosis, and the top of the spine should be positioned on C7 plumb line. I think the main issue is we have to have an X-ray to be able to measure the pelvic incidence, because some patients, they have low pelvic incidence, and some patients, they have high pelvic incidence. The patient that they have low pelvic incidence, we have to be very careful, because if we do any kind of osteotomy in the lumbar spine or we do interbody fusion, to overcorrect the lumbar lordosis, the patient is going to end up with a PJK. And that's the thing that happened initially when we learn about osteotomy, we overcorrect the patient, and those patients came back with further problems. Bertrand basically came with this picture. As we know, the majority of lumbar lordosis is at L4 to S1, like 75% at L4 to S1, 25% at L1 to S1. If we measure, we have 2 points. One of them is we call it inflection point. Inflection point is the point that lumbar lordosis convert to thoracic kyphosis. And for lumbar lordosis, we have a lower curve and an upper curve. Normally, the lower curve that's at top of L4 to S1 is equal to sacral slope, and the upper curve is equal to thoracic kyphosis. And in some cases, we can use that formula to be able to measure the sacral slope and the lower curvature of the lumbar spine. Dr. Rossoli from France actually did a lot of work for sagittal alignment. He talked about lumbar lordosis. He also talked about the spinal lordosis that you can get between S1 and the inflection point. Apex is split into spinal lordosis into the upper and lower arches. Lower arch is equal to sacral slope and upper arch is equal to thoracic kyphosis. Normally, is almost constant in normal population, about 20 degrees, or we can say sacral lordosis equal to sacral slope plus 20 degrees. This is the type of lateral X-ray schematic view that he defined. As you see, we have 4 types of sagittal curve in the normal people. Type 1 is, if you look at it, you see couple vertebrae involved in lordosis. Type 2, we have more involvement of vertebrae in lumbar lordosis. Type 3 is kind of equal, 50% thoracic kyphosis, 50% lumbar lordosis. In this type 1 and 2, normally the sacral slope is less than 35 degrees. Type 3 and 4, the sacral slope is more than between 35 to 45 degrees. And type 4, if you look at it, we have more segment involved in the lordosis. This is look at type 1 curve that we have thoracic kyphosis, sacral slope is at about 35 degrees. We have 1, 2, 3 segment involved in the lumbar lordosis. Type 2, we have more involvement of segment in lumbar lordosis. Sacral slope is less than 35 degrees. In type 3, we see the sacral slope is between 35 to 45. We have at least 5 or 6 segments in lordosis, and the rest is in kyphosis. And type 4, also we have some cases type 3 with antiverted pelvis. Those are very difficult cases to manage. And we have type 4 that you see sacral slope is more than 45. That we have more segments. What are the pathological factors? One is the question that we ask is effect of increasing thoracic kyphosis, overall flexibility of the spine, behavior of the spine and pelvis to local kyphosis, and behavior of the spine and pelvis to hyperlordosis. Okay, look at this case, the type 1, and we see the thoracic kyphosis is more than normal. Above and or below the kyphosis, is the kyphosis above or below the kyphosis, we see some changes happen in the piece. This is flexible. If the case is, if thoracic kyphosis is flexible, the correction is much easier compared to the cases that they have a rigid thoracic kyphosis. As kyphosis increase, we know the gravity line move forward. The pelvis rotate backward, we call it retroversion. The sacral slope decrease. Hips go to extension and knee go to flexion, and also sometimes the ankle go to dorsiflexion. That means it's the important alignment of the whole spine and axial and preferal skeleton together. What about cases that they have hyperlordosis? This is the case with hyperlordosis. Thoracic spine is pretty good. We don't see too much hyperkyphosis of thoracic spine. The patient underwent surgery to correct this hyperlordosis. In some cases that we see the patient has lumbar lordosis and thoracic kyphosis is less than normal. Those group of patients end up with problem at the level of T45. In some cases, they end up with increasing extension at the level of T2 to F3. So if lordosis is too long, kyphotic compensation is at T9, T10, and T11, and those cases may induce, operate on them, may induce PJK. Flattening of the spine to T3 may induce cervicothoracic PJK. Those are the cases that we do long fusion, for example, from T4 to the sacrum, and some of them end up with PJK at the level of T3. This is the case that, again, type 1, lateral curve, thoracic kyphosis is more than normal. In some of those scenarios, we see the patient has global kyphosis, that each one of them, they have a different plan of treatment. If we have a patient like type 1 with pelvic incidence less than low pelvic incidence, good option in those cases is pretty easy to treat them. If the thoracic kyphosis is reaching, it's going to be more difficult. Type 2, if the patient has de novo scoliosis, basically it's pretty easy to treat. And if we have antiverted type 3, as I said, those are the cases that lumbar lordosis and thoracic kyphosis, like a 50-50 in this group of patients, we don't have too many options. We have to be very careful about those group of people. This is the case with type 1. If you look at it, we have 1, 2, 3 segment lordosis. The rest is kyphosis. The patient has gentile scoliosis. And the patient underwent surgery with restoration of lumbar lordosis, both in coronal and sagittal. Again, a case with type 1. We see a couple segment in lordosis. The rest is in kyphosis. This patient has a rigid thoracic kyphosis. We decided to go to the upper part of the thoracic spine. This case is type 1 again, but has a flexible thoracic spine that we can stop at T10. This is another case that had a previous surgery. Had a lumbar couple segment in lumbar lordosis. The spine is in kyphotic at this area. I forgot to tell that normally between T10 to T12, the spine should be straight. If you have a thoracolumbar kyphosis, those patients, they have a difficult health-related quality of life. So this patient on definite extension for correction of this thoracolumbar. As type 2, as I said, we have more segmental lordosis. Type 2 with thoracic kyphosis like this one. Type 1 with thoracolumbar kyphosis like this one. And some cases that totally lumbar kyphosis and thoracic kyphosis with global kyphosis. For treatment strategy for type 2, maintain type 2 with short fusion. Normally, we don't want to go to the upper part of thoracic spine. We can start at T10. Like this case, the alignment both coronal and sagittal is normal. This is another case. Again, the alignment is pretty decent. If we have a type 1 and the curve is rigid, we can do a small PSO, and then 4. If you have a type 2, but danger with thoracic kyphosis reduction, in this group, we have to be very careful because if we correct the lumbar lordosis and also we decrease the thoracic kyphosis group. Antiverted type 3 risk of PJK. Normally in this group of patients, we have to do a PSO of L3. This is the case again with type 2 that because of rigidity of thoracic spine, the surgery extended to. This is a patient with type 2, mild de novo scoliosis. Look at this case, the patient had a fusion, they end up with failure at top of the fusion, and decided to extend the fusion upper level. If the patient has lumbar kyphosis, if degenerative, we can do a small PSO and then for turn it to type 2. The patient has a lumbar Scheuermann with very small pelvic incidence, unfortunately. We don't have too many good surgical options for this. If the patient has lumbar kyphosis, that means this patient is the spine is straight, just like the patient with previous surgery, we see those pit cages. Again, lumbar kyphosis with degenerative spine. Pelvic incidence of this patient is less than 50 degrees. The patient has a small L4 PSO. Correction. What is the failure by excessive lordosis restitution? If the patient has too long lordosis like type 3, with a small PI and balance by antiverted pelvis. In this case, PT is -4, sacral stroke is 42, PI is 38. What are the strategy of reduction of pelvic incidence? It is more than 50 degrees. Talk about those, about global kyphosis. Treatment strategy for type 3 or 4. As I said, type 3, we have more segment in lumbar lordosis. That means 50% in the thoracic kyphosis, 50% lumbar lordosis. In this group, again, if the thoracic kyphosis is flexible, we can get a fixation in the lumbar spine. Type 3, 4, for example, this is the case. Again, you see the lumbar lordosis that underwent short fusion. This is the case that lumbar lordosis is preserved. Patient didn't need any osteotomy, just posterior segment of fixation. If the pelvis is retroverted and you have thoracic kyphosis like this case, and also loss of lumbar lordosis, in this situation, maybe they do PSO for correction of lumbar lordosis, but we have to be very careful. Sometimes if the patient has a previous capacity and we do a corrective osteotomy of the lumbar spine, there's some chance for dislocation of the hip. So that's a topic that we call it hip spine syndrome that we have to be very careful about this group of patients. If the patient has a global flat back, strategy is basically maintaining the lumbar lordosis, correcting the coronal alignment, and maintain the lumbar lordosis. We can do small Ponti osteotomy at multiple levels. Basically, my point is we should be very careful about overcorrection of lumbar lordosis if the pelvic incidence, if the pelvic incidence of the patient is low, because if we overcorrect the lumbar lordosis, the patient will have the problem like the PJK and pelvic this case and the failure. And underwent osteotomy and extension. This case had a extension to thoracic spine. Big problematic piece adjacent to the previous. In conclusion, I want to say spinal curvature have reciprocal adaptive patterns. Pelvic incidence is the main factor of the spinal pelvic organization. Understanding of sagittal balance means understanding the relationship between pelvic incidence, lumbar lordosis, and thoracic. I believe the main issue that we have to check at first is pelvic incidence, and based on that, we have to do our rod bending for correction of lordosis.
Thank you very much, Dr. But the last.
In the name of the God of the soul and wisdom, who no thought is passing over than that. Hello, everyone. This is Dr. Vakili, Doctor of Chiropractic from CFCC of Canada, also the short practitioner from Germany. So I'm honored to be with you all. And special thanks to Dr. Khadigi and Dr. Rostami for having me today. So today I'm talking about we're going to go a quick review regarding, we're going to have a quick review regarding rehabilitation of spinal fusion surgery. The focus is on ASD, adult spinal deformity, and also lumbar spine. As you know, adult spinal deformity is an age-related disability that has a serious impact on physical health and quality of life of the patient. It causes sagittal malalignment from a wide range of degenerative changes, including paraspinal muscle weakness. Many studies have reported the effect of surgical treatment to improve pain and disability in patients with ASD. However, clear guidelines are yet to be established for rehabilitation after deformity correction, And there is currently no agreement regarding the timing and also the need for rehabilitation. We need to consider, even if the basic principles and desired outcomes of rehabilitation for these patients are the same, it is not clear whether they can achieve similar successful outcomes. So to design a suitable rehabilitation program for patients of relatively old age with ASD and degeneration and atrophy of back muscle, particularly the lumbar extensor muscle, and sometimes with long level of fixation, it is necessary to recognize the limitation faced by this patient and set the goal accordingly. Therefore, it is important to plan an individualized program for the patients. While rehabilitation traditionally starts post-operatively, the process should start before surgery as a pre-rehabilitation. This phase is an ideal time to make patients ready for an optimal outcome of surgery. Therefore, an individualized plan should include pre-rehabilitation plan, post-rehabilitation plan, and consider physical, mental, and psychological aspects of the patient. So why do we do pre-rehabilitation? As the population ages, the increasing surgical volume and the complexity of care are expected to place additional care delivery load in preoperative setting. There is increasing recognition that evidence-based preoperative pathway is associated with optimal outcome of surgery. And also, modern pain research has led to shift in treatment strategy from pain reduction to pain management, with a focus on teaching patients to manage their thoughts as a cognitive component and feeling affective component, which are both pain-related components. Pre-rehabilitation could target fear avoidance beliefs, as well as self-efficacy, as confidence, which are considered as a person's ability to stay active despite pain. This is what we want, to stay active despite pain, even preoperatively or postoperatively. For patients of working age, evidence suggests that treatment should include cognitive behavior techniques combined with physical activity. In patients, especially with low back pain, self-efficacy, fear avoidance beliefs are possible predictors of disability. So the therapist should measure and consider both items when treating the patients and should use a combination of techniques based on a cognitive behavior approach. If we look at the overview of fear avoidance model, if we have an injury, then we have a painful experience. So if we have low pain-related fear, then we have high functional self-efficacy and confidence. We confront the pain, and as a result, we have low disability, reduced depressed mood, and high physical activity level. But on the other hand, if we have high pain-related fear, low functional self-efficacy and confidence, we avoid movement, and as a result, we have high disability, depressed mood, and low physical activity level. So therefore, we need a pre-rehabilitation to fight this. The protocol generally in evidence suggests 4 individual treatment sessions before surgery and 1 booster session after surgery, like 2 weeks after. And depending on the patient's schedule, start from 8 to 12 weeks before surgery. But you know, in real life, really, we cannot do that sometimes, like probably most of the time, considering that patients come from another city, do the surgery and leave. So we can't really do that sometimes. So it is on the rehabilitation team that generally try to make it a little more like sort of feasible. If we can change the plan from like 4 sessions, even to 1 or 2 sessions, that would be great too. Even you can do it online. So whatever works for the patient, because the goal is the patient. So we need to work with his or her schedule. Generally in these sessions, the goal is like sort of cognitive interview to find out generally how they are feeling, like how their cognitions are, feelings are, behavior and body sensations regarding physical activity. And also instead of focusing on pain, we're focusing on functioning. We need to find out about psychological risk factor, which is very, very important factors when they are going through this surgery. So we need to find out with different kind of questionnaire, pain catastrophizing scale, Tampa scale, or self-efficacy for exercises. So you need to find out this risk factor, and as much as you can, treat them. Also, you can give them a homework. The homework is physical activity according to their sort of actions and whatever they can do. If you want to increase it or maintain it, you can find out in that session. The second session, you can talk about pain generally, talk about chronic pain, acute pain, and set a goal for them according to what they like, what they can do. For example, if they can do walking in a nearby forest for 30 minutes every day, because it should be a SMART goal, a specific, measurable, achievable, realistic, and also time targeted. So if they can't do that, they can do it at home. If they can't do that, if they like dancing, just go dancing for 15 minutes, whatever they like. So you can choose and ask them what you like and set the goal accordingly. Session 3 and 4, generally, we're going to follow up with the patient, whatever their homeworks are. If you're doing good, you can give them a report. You can sort of make them to have less anxiety regarding their surgery and help them to go through their pain. And also, you can set a goal at 4th session for week 4 and week 8 after surgery. This is, again, is a SMART goal. So again, the patient should choose 2 functions that they wanted to do, and they wanted to set a goal to reach that. Talk with them that this is a gradual steps toward their goal generally, so no worries, no rush, they're gonna get there. The session 5 is booster session. So you're gonna have these sessions 2 weeks after surgery. You can do it on the phone. You're gonna see how the surgery went, how their physical activities, or if you're doing great, how their fear avoidance are. Sort of, you need to know what you're doing, and if you need to change the goal that you set up before the surgery for 4 and 8, week 8, so you can change it. If you need to change the duration, intensity, frequency, whatever. So you need to just know what they are doing, and this is important for them because they know somebody cares about them. Advise them again to take the gradual step and no worries, and try to have less anxiety regarding the process. So then we go to the post-rehabilitation, post-operative rehabilitation. Generally, whatever we do, if it's physical therapy, if it's modalities, the aim and the goal is to improve patients' activity level, increase range of motion, and improve core strength. Usually, like most of the time, spinal fusion begins with early mobilization, including sitting, standing, and walking with support. So if you had that pre-rehabilitation session with the patient, you know that generally how you can start walking with them. So tell them, like, if you know how they are, then you can start the plan with the walking as better as possible. Generally, with spinal fusion, we don't have that much studies. There are different meanings regarding rehabilitation. Even there are wide differences among practitioners regarding utilization of physical therapy or other rehabilitation services. But generally, 2 things are key: customizing a program based on individual needs, and identification and treatment of any psychological barrier to recovery. So these 2 are very, very important. The recommendation in most studies is rehabilitation should begin immediately with education. You can give them pamphlet, leaflet recommendation on the day of discharge, nerve glides, and a walking program. So you can give them general information. This is a general information in some studies that regarding the activities that they might need to know after the day of discharge. If they wanted to drive, fly, having sexual activity, bathing, office work, manual work, heavy lifting, what the posture should be, they have to change it like every 20 minutes or every 40 minutes. Again, this is all individualized as well. So generally, if you know the patient from before, you have this general information regarding all the activities that they might have questions. So you can change it accordingly. If they need to be changed, change it on the day of discharge. If not, you can go through the activity, and if they have a question, they can reach you. So the literature support for passive modalities such as ultrasound, electrical stimulation, thermal agent, and other modalities has been decreased over the past 2 decades. Where physical therapy is mentioned, it often falls into several categories, such as general cardiovascular exercise, general strengthening training, soft tissue therapy, nerve mobility, joint mobility, patient education, and psychological intervention. So these are sort of the components that, according to their evidence, if it's sufficient or insufficient, or they have an aspirate, we're going to go through them slowly. I started with insufficient one. Generally, the first one is soft tissue mobilization. As you know, massage therapy is often used post-operatively to reduce inflammation, decrease pain, and facilitate patient recovery. And these changes happens after restoring lymphatic drainage, improving blood circulation, lengthening short or tight connective tissue, relaxing tense muscles, and generally soothing the nervous system. That's why they like it. It's soothing the nervous system. So generally, although there is insufficient evidence regarding soft tissue mobilization, but the recommendation is if you have a patient that have post-surgical pain and also have an anxiety and tension during the recovery, then you can use soft tissue therapy for the patient. The other one is nerve mobilization or flossing. Generally, this is controversial. Some believe that some didn't have any good outcome regarding it, but considering that early nerve mobilization is a safe treatment option in post-operative fusion rehabilitation to improve range of motion by decreasing post-operative nerve tension and decreasing scar tissue adherence to the nerve, then you can use it for the patient generally, especially early on. Joint mobilization. We know that we can't do any mobilization in the fixed area, but generally, the sort of evidence suggests that look at the higher and lower area. If you have any immobility, for example, if the fixed area is in the lumbar area, so look at the thoracic spine, look at the hip. The tendency of patients after surgery is towards stooping posture, having hyperkyphosis because it's fixed, they are stiff. So you need to try to mobilize the area safely in the thoracic area and in the hip area, which is important because we wanted to have the patient have a good posture, proper posture, increase functional mobility, and decrease stress on the healing fusion. Patient education, it's important, the NAS grade A, we need to have patient education in preoperative and postoperative. Every team member of surgical and rehabilitation have a message for the patient. So if you can do the preoperative rehabilitation, then you can make them ready, reduce them an anxiety, help them to go through the surgery, sort of as a pre and post-operative for the fusion rehabilitation. Make them ready for post-operative rehabilitation, and also you can improve the outcome while decreasing the pain, complication, and length of stay. Timing and duration. Generally, there are few studies regarding timing after fusion. There are some studies like Ostegaard and colleagues had randomized 2 groups of patients who underwent lumbar fusion to start rehabilitation at either 6 or 12. The group starting at 12 weeks showed improved outcome over the 6 weeks group in pain, ADL, ODI, and Dallas Pain Questionnaire scores, even 6 months follow-up. Generally, in the evidence we have, rehabilitation should start 2 to 3 months post-operatively, carry the patient to 6-month follow-up with the surgeon. And generally, the main thing that in evidence we have indication of is 12 weeks as the optimal time frame on average. But the recommendation is start initial assessment or evaluation start up to 4 weeks early. So if you have that booster session, 2 weeks, generally after the surgery, so you can do this too. So this is sort of like that. This is a booster session. So you can have it up to 4 weeks, or you can have it 2 to 4 weeks and find out more about patient, and then you can help them to have faster healing regarding their situation. Another study, I just wanted to put this to another study, was in 2018. They had lumbar fusion, and they had 2 groups of normal rehabilitation and standard rehabilitation, which was no exercises, and also another group of exercises twice weekly, 9 weeks, focusing on muscle activation on lumbopelvic stabilization muscle, which showed that 3 weeks after it showed that even after 3 weeks, earlier functional recovery was better than standard rehabilitation protocol. So again, we have different kind of evidence. This is all about individualized. So remember that individualized plan. It's important because we need to consider several variables such as patient comorbidities, preoperative deconditioning, age, disability, smoking, secondary orthopedic problems, psychological barriers, and even patient's commitment. So generally, if you know this before, during, before preoperative, so generally you can decide which is better for the patient. It's better to start 3 weeks than start 3 weeks. If not, then wait for the 12 weeks. So whatever works for the patient. Another component is cardiovascular. As you know, regular cardiovascular exercise positively impact long-term health without increasing back pain symptom after lumbar surgery, decreases length of stay, and improves our Ronald Morris score post-operatively. And emphasize is mostly on walking. So even preoperatively, post-operatively, walking is very, very important. Generally, if you have a patient that come into your office and ask them, what do? They do nothing. So when they do nothing, at least ask them to do walking, because walking really doesn't hurt them. They might have pain, but this is what we want. Be active, stay active despite pain. So walking is important, preoperatively and postoperatively. Recommend bike is good. If the patient has walking intolerance, you can ask them to do walking. Aquatic exercise is good too, but remember that it lacks weight bearing. So generally the recommendation is cardiovascular, do it pre and post. Motor control, another common element that is very, very important. Proper strengthening of trunk extensor and balancing of core musculature. A keystone of physical therapy, neuromuscular re-education is a key element for healing muscle, also new lumbar range of motion restrictions. So the exercises should be central to the core stability. So the recommendation is for sure use this muscle strength for post-operative rehabilitation. So we have different kind of exercises, evidence-based. Generally, recently, the exercises they have been used in research is McGill, is Yonda approach, Williams, McKinsey exercises. So according to the patient, that's why it's individualized. According to the patient, choose each of them is suitable for the patient. Sometimes the patient has flexion intolerance. So start with extension, start with McKinsey, and then go to flexion. And also you can choose one, you can choose two, you can choose all of them. You can choose each phase and change it. So this is all about the person goal. And also it depends on the rehabilitator specialty. So how to choose the exercise for the patient. Another study was in 2022. As you know, recently, the strengthening of gluteal muscle in rehabilitation has been very, very important because especially gluteus maximus in particular is known as significant muscle that allows numerous daily activity as well as maintaining of upright position. So thus we think that strengthening the exercise of gluteal muscle assists in maintaining sagittal balance and preventing sagittal decompensation after ASC surgery. So this is what they did in the research. Patients were age 65 and more with ASC. They have gone through surgery, the uppermost instrumented at T10, the lowermost at S1. And also they had malalignment, sagittal malalignment. So the post-operative program was first, the patient assisted performed sitting, dangling, leg rolling exercise and standing straight leg raise from the 3rd day after surgery. And then walking starts on the 5th day after surgery. And when they start walking, you need to tell them to stay neutral. The lumbar should stay neutral as much as possible. The exercise is performed 20 minutes, 3 times a day. And this is the exercises, the day 3 to day 5, sitting, dangling, leg lowering, leg lowering, standing, and straight leg raise exercise. And then you start walking, and then you add gluteal muscle strengthening. The gluteal muscle strengthening has been single leg stance exercise, walking high knee exercise, forward wall squat exercise. These are the exercises that was sort of focused on gluteal muscle strengthening. Again, was 20 minutes, 3 times a day. So generally, the conclusion was this protocol developed in this study effectively increased the gluteal muscle volume in patient undergoing long segmental fixation for ASD, and also protocol was effective in maintaining the optimal sagittal alignment after surgery. So this could be a good guideline for the patient that are going that undergo the reconstruction surgery in patient with ASD. Psychological barrier. Again, please consider psychological consideration because it's very, very important for the patient. The patient has significant fear of movement and re-injury after surgery. So we need to consider that and try to generally work with this situation, like comorbid anxiety, depression, also generally, like, depression, fear avoidance belief, any kind of kinestrophobia in the people that undergo lumbar fusion could like you can predict a worse outcome for them. So even the stressors such as financial costs, potential loss of income, compromised function. So in research, there are a lot of incorporating CBT and also teaching relaxing and coping techniques that you can teach them, and along with the rehabilitation, try to help them. And this is before surgery, preoperative psychological testing. So we need to know what kind of psychological barrier there are. The last word is, don't forget nutritional consultation with the patient. We are not going to talk about nutrition today. Nutrition is a big subject that has to be separately talk about it, but generally, preoperative malnutrition has proven to be challenging to define, diagnose, and treat. The suboptimal nutrition status is a strong independent predictor for of poor post-operative outcome. So please consider that. And you can have a specialist of like nutrition specialist in your team and ask them to help them. At least the basic principle is evaluate the patient for pre-existing malnutrition, try to optimize the malnutrition, minimize the starvation, prevent post-operative malnutrition, also support anabolism for recovery or any supplement that they can use preoperatively or post-operatively. These are just principles, and the nutrition specialist can use it more when they know the patient. It's all preoperative. So the summary, generally, we need to remember spinal fusion surgery is a long, sometimes scary journey for the patient. On this journey, the team of surgery and rehabilitation together can make this process easier for the patient. Rehabilitation starts before surgery. A program of rehabilitation should be individualized and should consider all the aspects such as physical, mental, psychological to be a successful plan. Remember, preoperatively try to, we can target fear avoidance belief as well as self-efficacy, which is very important because we wanted the patient to stay active despite pain and choose the cognitive behavioral technique and physical therapy together. Rehabilitation start with education, nerve light, and walking program immediately. And if you do the initial assessment 4 week or even 2 to 4 weeks, so you can have a better idea and understanding regarding the patient's rehabilitation program. Formally starts from 2 to 3 months post-operatively and follow up to 6 months. And these are the components that we talk about it. And I don't think we need to, again, to explain about it. Don't forget nutrition, please. And this is the end of the row. Thank you all for listening.
Thank you very much, Dr. Bakiri. Thanks a lot, Dr. Bakiri, and thanks a lot to all the speaker and audience. We are at the end of the webinar and we are closing the webinar. Thank you very much.